Good afternoon, everyone, and thank you very much for joining our webinar this afternoon on sickle cell awareness. July has been marked out as the Sickle Cell Awareness Month, and the University Health Services, in collaboration with the KNUST Wellness Centre and Novartis Ghana Limited, is bringing this webinar your way as part of efforts to create awareness about sickle cell, and also to be able to educate people about the sickle cell. I'm sure today we're going to have a lot to learn. So please brace yourself up, and I'm sure the time that you are going to spend with us will be very impactful and insightful. We have a video to show you while you wait and then get started. So please give us a few more minutes before I introduce the facilitator for this afternoon's session.
Hello, I'm Peter Amponsa, a staff of the university with the finance office, but currently posted to the Faculty of Agric. I'm a sickle cell person with the SS genotype. It's been a hell, but in all, I'll say God has been good. A lot of people think sickle cell persons just fake. Those especially who have not encountered, and even those who have encountered sickle cell persons, some because they don't feel it within their own bodies, they think it's just something that is ordinary. But let's put it this way. If, let's say, you are having a headache and you take a simple paracetamol and it relieves or goes within, say, 30 minutes, and compare it to somebody who is a sickle cell person, either an SS or SC person, and even sometimes people who are AS and AC people also would have some pain here or there, just that they cannot be referred to as sickle cell persons. You take your simple paracetamol and it's gone. But the sickle cell person will go on and take stronger painkillers, even to the extent of taking those narcotic medications, and yet still be in pain. Sometimes you may not have an idea of what the pain feels like. Somebody sitting somewhere may think you are just dramatizing, but it's real. The challenges are enormous. The complications are more than you can imagine. We have emotional, psychological, and social issues. My own personal experience, I've gone through a lot. I had to repeat in the primary school for about 2 times before finally I got to the secondary school. When I was at Opokuware secondary school, during my secondary school days, fine, things went on well. Not without challenges, not without occasional stays in the hospital and all that. But what broke the camel's back was when I was writing my final WAEC exams. Right after the physics practicals, I was a science student. I did physics, chemistry, and maths. Right after the physics practicals, I couldn't walk out of the lab, even though I was able to successfully do the lab work. I had to be carried and brought straight to the KNUST hospital here from Santase, Opokuware to this hospital. I had to write all the other papers whilst on admission at the hospital, having blood transfusion, and infusions, so both hands were occupied. Every time that I had a paper, the infusion and the transfusion had to be taken, and I would have to be transported all the way to Opokuwari, because along the line they said they couldn't get invigilators to come to the hospital to help me. And so I wrote all the papers this way. I'll go to Opokuwari school, write, come back to the hospital, and then the process will continue. It has been so. When I came, I had to divert from science to do accounting as a result of these things. This sickle cell thing is really real. The amount of money I spend monthly on medications and other things just to make sure that I go and come, you may not have any idea about it. If I want to go on, I can go on and on and on. But I just want to let you know that if you are yet to get married or you are contemplating, please make sure that you go by what has been told you, by way of trying to find somebody whom you are compatible with in terms of sickle cell or any other blood disorders. Please, if you perchance meet any sickle cell person, know that every day he or she lives with pain in his or her body. Well, a lot of sickle cell persons have passed on. I've met many who have passed on. It is just by the grace of God. But there have been sickle cell persons who have lived well over 60 years. My own mom was an example. She was 66 years before she passed. I have told myself I'm going to be 90 before I go. But if I will be able to turn that 90, I need your support. Or people like me need your support. My resolve is that nobody should ever suffer sickle cell. So carry out the message and tell people to test before they say I do, because it is not easy. You, the parent, what you go through is so much for you to carry. If you have to wake up deep in the night to rush your child to the hospital, if your child, when he grows, have to rush in the deep of the night to rush him or herself to the hospital, then you realize that it is not an easy task. So please, do not joke with this education that is going on all around. Take it serious. The monies that I have used on medication for myself, if I had built a 4-story building, maybe I would have completed by now. So please, kindly make sure that you test. And any time that you meet any sickle cell person, we don't need any sympathies of yours. We need only your empathies. We don't need you to be tired of us, but we need every encouragement of yours. We need every support of yours. Not that we are weaklings. Yes, we are struggling. I work for myself, I feed for myself, I tend for myself. I may not need your money, but I need your encouragement and your support. Thank you for listening and watching, and I hope you would make sure you test before you say I do. Okay, so on this note, I would want to gladly invite you all to join the webinar that is going to go on the 12th of July, which is going to be in collaboration with the KNUST Wellness Centre and then the KNUST Health Services, as well as Novartis Ghana Limited. on the topic sickle cell. So please avail yourself and invite others. Thank you.
Thank you very much. And once again, welcome all of you for making time to join this very informative and educational webinar on sickle cell. We thank you for your time, and we are grateful to the KNUST Wellness Centre that is leading and collaborating with Novartis Ghana and the University Health Services. Without much ado, I'd want to introduce the facilitator or speaker for this webinar. So our speaker or facilitator for today's meeting is a pediatrician and a senior lecturer in the School of Medicine and Dentistry. She has over 21 years of experience in medical practice. She works at the Komfo Teaching Hospital as a specialist pediatrician. She holds a bachelor's degree in medicine and surgery from the School of Medical Sciences, KNUST, and a postgraduate training in pediatrics from the West African College of Physicians. She's a fellow of the West African College of Physicians and the Ghana College of Physicians and Surgeons. Her work involves teaching medical students, physician assistants, emergency nursing students, and students from other allied health facilities. Her work also involves the clinical care of pediatric cancer patients and others with hematological problems, especially sickle cell disease at KNUST, which is a tertiary referral center in Ghana. Over the last 15 years, she has gained extensive experience in undergraduate and postgraduate teaching and in research in Ghana. She's currently heading the Pediatric Hem-Oncology Unit at Komfo Anokye. She's involved in various studies, initially with the STD Newborn Screening Project and then the ODIS Project. She was the co-PI for Sparkle 1 for the Ghana site and involved in the Sickle Gene Africa Project. She's currently the principal investigator in various ongoing clinical trials in sickle cell disease at KNUST. She has over 80 peer-reviewed articles and published abstracts to her credit. Ladies and gentlemen, it's my singular honor to introduce to you Dr. Vivian Paintsil. Dr. Paintsil, you have your audience. Thank you very much.
Thank you so very much, Dr. Ayisibuati. I'm grateful to you all for this opportunity to talk about sickle cell disease, which is my passion. And I believe that at the end of this 30 to 45 minutes, we will all have been able to learn something about sickle cell and know how to help our friends who have sickle cell disease. And so I will start with what the World Health Organization have said. We know that sickle cell disease has been acclaimed as a disease of public health importance because of the numbers that comes with it. And as a country, we need to focus more on sickle cell disease because if you want to measure health impacts on our country, it is measured by our under 5 mortality. So if we have a very high under 5 mortality, then we need to know how to manage it well. And then the disease that contribute to that under 5 mortality are diseases that we have to really be able to tackle well. And so from this report, it was seen that in Africa, about 5% to 16% of our under 5 deaths were from sickle cell disease. And in West Africa, some of our individual countries had around 16% of their under 5 deaths coming from sickle cell disease. That shows us the importance of sickle cell disease and why we need to be able to tackle it. So when we talk about sickle cell, what is it? We normally say that sickle cell is a generic term that is used when an individual has 2 abnormal hemoglobin genes. At least one of those abnormal hemoglobin genes should be hemoglobin S. So in the body, there are different hemoglobin. We have hemoglobin A, which normally is a normal one. And then we have hemoglobin S, which is abnormal, hemoglobin C, which is also abnormal. So anytime you have a disease that has a combination of S with any of the other abnormal hemoglobin genes, then that is sickle cell disease. And the disease was named sickle cell because it was similar to that farming tool that we call the sickle. If you look at this picture here, you can see that there is this instrument here called the sickle, which is used for farming. And if you look at these cells that you can see here, these are like crescent moon and they are sickle. Currently, even it's being redefined. And if you look at the sickle, this also looks like a banana, and banana is more comparable to how the sickle RBC looks like. And so currently with newer terminologies that are coming, it's even being said that we should even call them banana cell disease instead of the sickle, because a lot of Africans don't relate to sickle cell. But we know that we still call them sickle cell disease. And so we expect that our RBCs will be round like a donut. And so in times of stress, in times of dehydration, then the cells will sickle. And all the symptoms that patients with sickle cell disease have is because of that sickled RBC. And if we look at our part of the world, sickle cell disease has been a disease that has been known by our grandmothers, by our grandfathers, by our great and great grandfathers. Because if you look at all our dialects, there are names for sickle cell disease. We call it Abututu in Tree. In Fanti, we call it Irere. Gans call it Chichi. And then all the other, now all the other dialects, there are different names for sickle cell disease, letting us know that this disease has been there from our great and great grandfathers. And so it is not something that is new. So they knew it, but we need to know how we help our patients so that they can do better. When we talk about sickle cell disease, there are different types of sickle cell disease, but the commonest one that we have in Ghana is a sickle cell disease, SS. We have the sickle cell disease, SC. We have the sickle cell disease, S beta 0 thalassemia. And then we have the sickle cell disease, S beta plus thalassemia. There are different ones, SO, Arab, SD, and others that are there, but they are not common in our parts of the world. But these are the common ones that we can see. And let us also know that when you have AS, you don't have sickle cell disease. We normally call AS the S trait or carrier. Okay, so that person doesn't have the disease, but can transfer that disease to another person. And then if you have the AC, you don't have the sickle cell disease. You have the C trait, or you are a carrier of the C. And so someone who has the AC is not a sickle cell disease. So we need to have that at the back of our mind. But they are important, the traits are important, because if you don't know that you are a trait, and then later on, two of the traits marry, you can later on have a child who has sickle cell disease. And most of the time, people will come and tell you that, oh, I don't have the disease. I don't have the disease, my children have the disease. It's because possibly both of you have the trait, or both of you have carriers, and then later on, you had a child who had the disease. So in terms of the prevalence of the sickle cell trait, in West Africa, we have up to around 30.7% of our population having the AS, which is the S trait. And so if you have a very high population with the S trait, then there is a chance that in the population that you have, those with the disease might also be high. And in Ghana, those in the southern part of the country have a lot of the AS. And as you go to the northern part of the country, there is also a very high prevalence of the AC trait. About 25% of the population have the AC trait, as compared to around 30% of those in the southern portion, which have the S trait. So if we talk about the trait, as I was saying, we have more of our population in the southern portion having more AS as compared to those in the northern portion who have the AC disease. So let's talk about the disease burden. In Africa, lots of the diseases from sickle cell disease come from countries like Nigeria, and then DRC, the Democratic Republic of Congo. And then also, we have lots of people from India also contributing. So these countries contribute to about 50% of all the sickle cell disease bed worldwide. And it is known that about 300,000 newborns are born every year with sickle cell disease. So if you calculate, that would be like 1,000 babies born each day. But just can be just an understatement, because if you look at the world, apart from the North Americans and possibly in the Europe, most of that we don't really have any national level surveillance. We don't have newborn screening data. We don't have a registry. So all these that we are estimating can be an understatement. And it's possible that we might have more babies born every day for sickle cell disease. And so let's look at this data that we have. In Africa, we see that approximately an average of 1 out of every 50 birds has the disease, has sickle cell disease. So if we look at Nigeria, the current data shows that 1 out of 66 newborns have the disease. If you look in Ghana, in the 2021 data, 1 out of every 58 birds has the disease. Okay. And so if we know that, then that means we need to be able to pick up these babies as early as possible so that we can go ahead and manage them. Because I believe that when we were growing up, there was always this thing about, oh, this child will not be 5 years old. This child will not be 10 years old. It will not be 18 years old and all that. They don't grow. But we've seen that when you institute good interventions for them, patients with sickle cell disease can make it. You can have them in the 60s, in the 70s, and 80-year-olds because you have instituted very good mechanisms for them. And so, as we know that we are about 1 in 58, we need to be able to make sure that we pick these patients so that we can be able to institute clinical care for them. So the hallmark for every patient with sickle cell disease is the pain that they have. That is due to a phenomenon that we call vaso-occlusion. What happens is that your red blood cells, which are supposed to be round and donuts, in times of stress or dehydration, it becomes like a sickle. And then these sickle cell elaborate some molecules on themselves. And these molecules, we call them adhesion molecules. So it makes the red blood cells stick together. And when these red blood cells stick together, it forms polymers or tactoids. And then instead of being able to flow freely through your blood vessels, it's not able to do that. So in the end, it blocks your blood vessels and oxygenation to the end organs is impaired. And anytime you don't get any oxygenation to the end organ, then it leads to a lot of pain. The pain are quite unpredictable. And so you have one patient who is here right now, and then in the next 5 minutes will have very severe pain. It's not that they are making up the pain or anything like that. No, they are in severe pain. It is very unpredictable, and then you might have to need to intervene before that patient can do well. And what is known is that these vaso-occlusion crises and basically these pain crises mostly impact on the quality of life that our patients have. And that also, when it happens in any of the organs, it can also lead to organ damage. So you can have all these vaso-occlusions in your brain. You can also have it in your lungs. And so if you have it in your brain, you can imagine what will happen. In the end, that patient can have complications like stroke. If you have it in the lungs, a patient can't breathe and can get severe breathlessness. And if nothing is done, patient can die as a result of it. So all these problems, when they culminate, it leads to a decreased quality of life for our patients. And so it is something that we need to go ahead and make sure that we intervene for them. Apart from vaso-occlusion, the other complications that can come is the hemolysis that patients with sickle cell disease normally come with. Our normal red blood cell is supposed to live around 120 days, but when they are sickle, they live for just about 10 to 20 days. And because of that, lots of patients with sickle cell disease have a very low hemoglobin level. And that also impacts on their quality of life. Because if you have a low hemoglobin level, most of the time you are fatigued. And so what you expect them to do in terms of their performance at workplace and other things, they don't even have the energy or the strength to do that because of that low hemoglobin that they have. But with proper management and interventions, patients with sickle cell disease can do better. Let's look at the inheritance of sickle cell disease. So if you have two patients who have sickle cell disease, possibly they are in their 20s and then they are going to marry. And then one has sickle cell disease, possibly SS, the other has SC. Anytime that they give birth to a child, that child will definitely have the disease. Either it will be an SC disease or an SS disease. And so we can go to the one when you have one of the couple being the trait. So the trait means whether you are AS or you are AC. And then you have a mother who is normal, so doesn't have any of these S. So that mother is A. If you have that, you have a chance of having this about 50% chance of having a normal child who has hemoglobin AA, and then you have a 50% chance that that patient might have the trait, which is if it's an AS or an AC. When you have someone, a couple, a father who has sickle cell disease, any of them, and then you have a mother who has an AA, the chances is that all the children they give birth to will have the trait. So either it's an AS or it is an AC. And then let's see a couple. The father has a trait, the mom has a trait. For them, there is a 25% chance that they can have a child who has a sickle cell disease. And when we are talking about chances, probability, if we say 25% chance, that means it is with every pregnancy. Anytime that you give birth, there is a chance that that child might have the sickle cell disease. And so it is not that you have 4 children, one will be sickle cell disease. No, that is not how it goes. So there is a possibility that you have 4 children and all your 4 will have sickle cell disease. Or you have 2 and none will have the disease. And so it is all probability. We don't decide who comes. It's God who does that for us. So whatever probability happens, that is what you will have. And let's take the one who has a sickle cell disease and a trait. For that, you will have a 50% chance that your children will have a trait, and then a 50% chance that your children will have the disease. And this at times can be problematic, especially when people do the screening and then they just do the Sickle test and then they are told that you don't have the disease. But that patient might have hemoglobin AC. AC, when you do the Sickle test, will tell you that the Sickle is negative. And so the fact that you have Sickle negative doesn't mean that you don't have sickle cell disease. Possibly you don't have the S, but it doesn't mean that you don't have the disease. And so it is always better that you go ahead and do better tests whenever you are doing your screening for sickle cell disease. Because in this case, there is a 50% chance that you can have the disease. And it's a probability, so anything can happen. So let's take this animation of these 2 individuals who have AS. So for that, you can see that they can have a chance, a 25% chance of having a child who has AA, which is normal, a 50% chance of having children who are AS, which is a treat, and then a 25% chance of having a child who has the disease, which is SS. And so there is this chart which tries to do the permutations for all the different types of phenotypes that you can get. Let's take someone who has SS and someone who has a trait, AC trait. You can see that they can have this possibility of having an SC, a 50% chance of having an SC disease. If you are two traits, AS and AS, you have a 25% chance of having a child who has an SS. So the best for patients who have an SS disease is for them to marry someone who doesn't have any abnormal hemoglobin G. So your AA, they are the best. If you have an SS patient who gets married to an SS patient, all your children will be SS. An SC and an AS, you have a chance of giving birth to a child who has an SS and then also an SC. And then if you have an SC who marries a patient who has CC, CC is an abnormal hemoglobin, but it is not a sickle cell disease. They will also have a chance of marrying an SC disease. And so with this, it is always advisable that if you have the traits in your life choices, you have to make sure that you have someone who has an AA. Normally, they will always are asking. Most parents won't even, immediately they hear that, oh, this boy that you are bringing, or this, your fiancé or fiancé has a sickle cell disease, then the parents become agitated. But if we don't allow them, then how are we going to reduce even the number of SCD patients that we have? We normally advise that if you have an SS or any of the traits, the best is for you to have someone who has an AA. But when you come, what we will do as healthcare practitioners is to advise you. We can't make the choice for you, but we will advise you to know what difficulties you can go through if you go through with your choice. When we talk about sickle cell disease, there are triggers of the sickling episodes. And mainly if you have a patient who decides possibly, oh, it's Easter time, let's go up to the mountains and hike and have some fun. Being at high altitudes normally can trigger sickling. And also changes in temperature can trigger sickling for them. And infections are also things that can trigger sickling. And then stress. We know that especially for our students, around exams time, that is when you see lots of the SCD patients coming to the hospitals with vaso-occlusive pain episodes, because the stress triggers the sickling episode and it leads to pain for them. And not drinking enough also leads to dehydration, and that can also cause sickling episodes. And so we always encourage our patients that try and drink as much as possible. Always go somewhere, wherever you are going, with some bottle of water so that you can be able to drink and be well hydrated. Because when you're well hydrated, you reduce the chance of having these sickling episodes. So how do we diagnose our patients? The best is for us to be able to have newborn screening for all babies who are born in the country. When we talk about newborn screening, when you do that, it reduces morbidity and mortality because you are able to pick the patients or the babies who have sickle cell disease early enough. And then immediately we pick them. We start with them on prophylactic penicillin. What this penicillin does is that it protects them against infection. The very severe infections that patients with sickle cell disease have are infections with Streptococcus pneumoniae. And that's with just penicillin, at twice daily dosing, patients are protected. And so if you know that your patient has sickle cell from 2 months, we normally start them on penicillin, and that protects them from these infections. Otherwise, you will see that the baby will be growing. And as this baby is growing, you see that they get fevers, recurrent fevers. And most of the time, these are the ones that kill them in the early infant. So by 1 year, by 2 years, then you see that they are dead. And because they possibly had a strep pneumos infections of the blood. And so with just penicillin prophylaxis, they normally do well. And when you know that your patient has sickle cell disease right from 2 months of age, we normally continue and provide ongoing care. With a newborn screening, mostly we do a test that we call isoelectric focusing. So we take blood sample from the heel of the baby's foot and then put it on a filter paper and send it to the lab so that the lab can check whether the patient has sickle cell disease or not. And if you know, with an ongoing care can be done. At Komfo Teaching Hospital, we started the newborn screening from 1995. And so it's been done for quite a while. And this is a picture of what happened at that day. There was the first baby that had the first heel prick. And this baby, although was negative, but this child is still alive. We just recently went to track this child, and the child is still doing well. And that is what we want, that patients will be picked very early, immediately they are born. We should be able to pick them and then know whether they are SS, they are SC, they have their traits, and then be able to know what to do with them. If they have the sickle cell disease, then we should be able to enroll them in the sickle cell clinics and then give them ongoing care. Because if we give them ongoing care, then always the connotation that we have that, oh, sickle cell disease patients don't live and all that. After some time, all that will go because they are being treated, they are being managed, they are being given comprehensive care. And so they will live long and then they will have a good quality of life if all that is done for them. So apart from the heel prick that you can do for older children, normally we encourage that you do hemoglobin electrophoresis test. You can see that I haven't written the Sickling test here because if you do your Sickling test, all it tells you is that you are either Sickling positive or Sickling negative. It doesn't tell you whether you have the disease or not. And so you might have to go ahead and do other tests, which is the HB electrophoresis, before you'll be able to know whether you have the sickle cell disease or not. And so it is recommended that you go ahead, do the HB electrophoresis. And the fact that you have Sickling negative doesn't mean that you don't have any other hemoglobin variant like your hemoglobin C and all the other ones. It's possible that you might have the other ones. And if you don't know, you can get married to someone who has the AS trait, and that can cause problem for you because you might have an increased chance of delivering a child who has sickle cell disease. Currently, there are other point of care tests that are done. We know that for the traditional newborn screening that is done, the test, you take the blood on a filter paper and then send it to the lab. It takes about 6 weeks for you to get your report back. But the point of care test is like the rapid diagnostic test for malaria. You can get it done and then you can get your results. So there are different ones on the market. We have the sickle scan, we have the hemotype SC, we have the Gazelle. And then the hemotype SC has been found to be comparable to the isoelectric focusing for newborn screening. And so it's recommended that you can even use that for a newborn screening. And so after you've been able to diagnose your patients, you might need to teach the patient or the parent about the clinical presentation. So there are other clinical presentations that you need to know about. The earliest clinical presentation you have, which mostly comes around 6 months of age, is the hand and foot syndrome. So for that, you see that there is swellings of the hand and then swellings of the foot. Okay, and that's, you will see that the baby becomes very irritable, they cry, and then their hands and feet are swollen. At times, some of them can have a fever, others might not have a fever. And so for patients like this, even if you don't know that the patient has sickle cell disease, this can be an indication for you to go ahead and test, because it is a possibility that the patient will have the disease. And then when you know that the patient has hand and foot syndrome, then what you might need to do is to give adequate pain control, bring the patient to the hospital for us to manage appropriately. The other things that patients can also present with is with jaundice, yellowish coloration of the eye. In one of my earlier slides, I spoke about the way that the hemolyze, the RBCs break down. And when the RBCs, your red blood cells, break down, normally what it leads to is that they can get urine which are dark, like Coke. So if you look at this urine sample here, this is a clear sample, doesn't have anything, but this is how hemolysis looks like. The urine is cola-like or like malt in some cases. And when that happens, you can see that the patient's eyes are also yellow. And lots of patients with sickle cell disease have this yellowish tinge or just a tinge of jaundice, because most of their time, their red blood cells are almost always breaking down. And so it releases a lot of bilirubin and then makes their eyes yellow. But when there is an exacerbation of the hemolysis or the breakdown, then you can see that there is deepening of the yellowish coloration of the eyes. And subsequently, you can see that the urine will also change color. The other thing for you to know is about splenic sequestration. In our abdomen, at the left side, there is an organ there that we call the spleen. And for patients with sickle cell, they can decide to pull blood into the spleen. So the spleen pulls all the blood. And in the end, they get very enlarged, and then it's very tender or painful. And then if you're not careful, patients also have a drop in their hemoglobin level. They become anemic, and then they become pale. And some of them can even go to shock. And if you don't resuscitate appropriately, they can die as a result of sequestration. And so we normally train our mothers to be able to palpate the abdomen so that they can be able to detect it when the spleen is increasing in size. And that will help them so that they can bring those patients to the hospital as early as possible. This figure shows you everything in the body. So if you look at this figure, you can see that every part of your body can be affected with vaso-occlusion, right from the head to your foot. So you can see that for children, those less than 10 years, there is a very high incidence of stroke. A lot of people don't believe that children have stroke, but when you have patients with sickle cell disease, they can get stroke in their early age. And apart from that, they can get problems with their eyes. The vaso-occlusion can occur in their eyes and can lead to blindness. They can get infections and infarction in their chest, leading to an acute chest syndrome, which can also lead to congestion of the lungs. And when the lungs get congested, it can lead to death for that patient. The heart can be affected. The liver, the spleen can all be affected. Your kidneys, some of them can get what we call a nephropathy. The kidney can be affected. And that can also lead to a kidney failure for them. And then a lot of patients with sickle cell disease in their adolescent and young adult age can get chronic leg ulcers. And so they get an ulcer, it doesn't heal because perfusion is impaired because of the vaso-occlusion that they normally have. And so when you have a patient with sickle cell, all these, a barrage of complications can happen. And as the one in the video said, we need empathy for them, not sympathy, but we need to also encourage them so that they can come to the clinics, such that some of these can be picked up as early as possible, and then on, we can go ahead and then we can manage them appropriately. Apart from these complications, there are also a lot of psychosocial problems. Anxiety. Major problem is the stigmatization that we normally stigmatize them. sickle cell disease is not an infectious disease. It's not a contagious disease. And so we should allow our children to play with children who have sickle cell disease. And we as parents should allow them, our children, as they are growing up, to be able to play up to what they can do. Because at times we stigmatize them, and then their friends also stigmatize them. And that leads to a lot of anxiety, psychological distress for them. And because of how their HBs are also low, they can also get recurrent fatigue. And some of them also are not able to also concentrate well, especially for those who have a previous stroke. Some of them also have a lot of sleep disorders. And all these psychosocial problems are very, very pertinent and need to be taken care of. Some of them will tell you that they are scared because they wonder whether they can be able to give birth in future. So as you talk to the adolescents, their sexual dysfunction and infertility are things that they think about. Am I going to be fertile? And so a lot of them will need a lot of psychosocial support as they grow up so that they can be able to do much in life. And then we need to encourage them that no matter what, in spite of their disease, they can still make it in life. How do we prevent our crisis? First, we have to make sure that they have adequate fluids, because we know that dehydration causes lots of the sickling episodes. So making sure that they always have fluids in hand as they go to school, in the house, whenever they are outside, they have to have their water with them and drink. And also avoid too much exposure to the sun, because that causes dehydration and can cause problems for them. And things that prevent oxygen loss is for them to avoid excessive physical activity. And then things that will cause emotional stress, we normally encourage that they sort of reduce it, or they learn how to better cope with it. There are therapies that they go through, the cognitive behavioral therapy, so that they know how to manage their stress. And then things like high altitudes and all that, they need to avoid it. And then if they are smoking, we tell them, currently there's lots of smoking around, all this shisha and other things. We tell them that precipitates the crisis. And so as much as possible, you need to stop or don't go near anywhere where you'll be encouraged to smoke. It's important for us to monitor them as healthcare workers, making sure that their growth and development are good, making sure that their nutrition is adequate, and then examining them appropriately so that you'll be able to pick up any abnormality that picks up. And then looking at their acute complications that they come with. If you looked at the figure I showed before, you can see that there can be lots of acute complications, but if you don't monitor for them, you can't be able to pick them up. So we need to make sure to monitor all of that with our lab investigations. And then special studies are done. We have what we call the transcranial Doppler, which we use to check if there is any risk for stroke for some of our patients. And so things like that can be done. You can also check the eye to see whether there is any abnormalities in the eye vessels, so that you see whether that patient has a higher risk of getting any visual disturbances. So for health maintenance, there are different things. We normally encourage that we immunize them. So gladly for Ghana, for our childhood immunization, most of the vaccines that are given are what is needed for patients with sickle cell. So we encourage them to make sure that they go for their childhood immunization. And then making sure that they also use their penicillin prophylaxis. And then currently we have hydroxyurea, which is given for a specific group of patients. And hydroxyurea has been shown to increase their hemoglobin level, and thus reducing fatigue for patients with sickle cell disease. And with that, it makes them better. It reduces hospitalization also, and patients' quality of life also increases. Folic acid is needed because patients mostly have a type of anemia, and folic acid helps so that it rebuilds the red blood cells for them. And then hydration. For sickle cell disease, we always mention hydration, very important, so that you are well hydrated, because if you are well hydrated, it reduces the chances of you getting sickling, and then reduces the complications that you get, especially your vaso-occlusive crisis. And then we need to screen for complications. We need to check the eye from 10 years of age, whether there are any visual disturbances. Between 2 years and 16 years of age, we need to also do the transcranial Doppler to see the risk for stroke for our patients. We need to check their kidneys and see whether the kidneys are okay, doing our urine investigations to screen for nephropathy in our patients and other things, cardiac complications. We need to screen for all of them to make sure that our patients have the best quality of life. So in terms of our treatment, currently there are so many treatments, some in experimental stages. Currently, hydroxyurea is currently on insurance for patients with sickle cell disease. And there are other drugs like L-glutamine, crizanlizumab, and voxelotor, which are also FDA approved. But in Ghana, voxelotor, crizanlizumab, L-glutamine is not readily available, but you can get the hydroxyurea. And currently, we are moving from not just giving only drugs, but doing transplants. Greater Accra Regional Hospital can do some transplant for patients. And it is recommended, but for patients who fit the criteria, you can go ahead and do transplant, because transplant is the one that lets that patient who has a sickle cell disease say confidently that I don't have the disease again. And then also gene therapy. Gene therapy is currently in the experimental stages, but there is a hope, and the evidence that has come out is quite promising, and people have been cured by using gene therapy. And so it is being hoped that with time, we should be able to have our patients in Africa getting gene therapy, being cured of the disease at a very good price, because currently the price for gene therapy is quite exorbitant. So if we bring it to our part of the world, it might be very difficult for us, but it is something that is in the pipeline, and hopefully with time, our patients should be able to afford this so that we can cure our patients with sickle cell disease. So if we want to control sickle cell disease in our part of the world, what can we do? Genetic counseling is very important. And then we need to screen our patients at all levels and age groups so that everyone knows their phenotype. And then also we need to educate, especially our trade, those who have AS, those who have AC, so that they know the implication of that. Because if you have AS and an AC, and then you marry, although both of you don't have the disease, you can give birth to a child who has the disease. So that public education for our trade is very important, especially if we are in a country where about 25 to 30% of us have the trade. We need to emphasize our public education. And then also we need to make sure that our newborn screening is done holistically, universal newborn screening for patients with sickle cell, so that those who are found to be positive will be enrolled into a sickle cell clinic, giving comprehensive care. And we know that if we give them comprehensive care, lots of them can do well. So for us in Ghana, what we need to do is to make sure that our regional SCD centers do well, because currently for some of the regions, there are no sickle cell disease treatment centers, but there are patients there who have the disease. And then the use of the hydroxyurea, where we need to train our centers so that they know how to use hydroxyurea, especially since it is now on insurance. And then the availability of our clinical management guidelines for all the different referral levels. And then also those in the higher referral levels, like those in the tertiary hospitals, also being part of the management, inputting into the management of those in the lower referral level. That can help so that patients who are at the lower referral levels can also get quality care. And then we should also have multidisciplinary team members who will help in the management of the disease and be able to manage our patients from pediatrics to adolescents to adults so that all of them can get the quality care that they need. And genetic counseling for all of us, for our families, and advocacy. Advocacy is very important because we advocate not only for them, but also for our future generations so that they can also get the best of care. So if you look at those maps that I've shown, we have around about 31 treatment centers in Ghana. And you can see that most of them are concentrated in the Ashanti region and then the Greater Accra region. But what happens to all the rest? Patients are all around the country. So that is where the advocacy comes in, where we need to advocate so that patients from all the other parts of the country can have sickle cell centers, Ahafo, Savannah, Uti, and all these, Upper West, Northeast, can all have sickle cell centers so that patients there can go and then be able to be managed appropriately. So, in conclusion, we've talked about sickle cell disease. Let us all know our status because it is when you are informed, that is when you make a good decision. So let us all make our good decision, test and make very good decision. Let us advocate for universal newborn screening for sickle cell disease. And then genetic counseling services, it should be available everywhere so that we can walk into a hospital, have genetic counseling services. So let's be their support, okay? It's very important that we be their support. Thank you very much.
Thank you very much, Dr. Paintsil. That was excellent. I've learned a lot, and I'm sure the participants who have joined online have also been very well educated about the subject of sickle cell disease. Thank you. We are most grateful. I'm sure if this was an in-person session, we would have had a round of applause, but we are very grateful. There was a question in the chat box from Dr. Jemfi asking about the role of aspirin in stroke in a patient who presents with, who has sickle cell and has a stroke. Do you give aspirin? And if it's a child, the risk of Ray's syndrome, how does aspirin come in when it comes to stroke in sickle cell patients?
Okay, so for patients with sickle cell disease, most of their strokes are infective. So it's from the vaso-occlusive crisis. That is why they get a stroke. Just a few of them that are hemorrhagic, but most are infective. So in management, aspirin doesn't really play a crucial role. It's basically with your supportive care and then with your physiotherapy and then making sure that if it's an infection, a lot of them can recover, but there is always the risk that if you have a first stroke, there is always a risk that you can get a second stroke. So what we normally do is to make sure that the patient that doesn't have severe anemia, as much as possible, we put them either on chronic transfusion or that patient is put on hydroxyurea. And when that happens, a lot of them don't get the second stroke and are able to do well.
Thank you very much for that response. I'll please ask that if you want to ask a question, you can either type in the chat box or you raise your hand and we'll give you the opportunity to ask your question. Or if you have a contribution, an addition, we'll be happy to have you speak. I see Dr. Jacqueline Esibe. Yes, Jacqueline, please unmute and then go ahead. Thank you.
Yeah, thank you very much. Thank you, Dr. Paintsil. Really great lecture. I've learned a lot of new things. And just in connection with the children with stroke, I want to know, do they all have to be on the hypertransfusion protocol? Thank you.
Okay, so the standard of care for the children with transfusion for the children with stroke is to do the transfusion. But we know that when you do your chronic transfusion, it comes with a lot of problems. Mostly the major one is your iron overload. And we know that in our part of the world, at times getting those chelators for that iron overload is it's expensive and not readily available. But we know that studies have shown that giving hydroxyurea has been able to reduce that incidence of stroke. When you have patients with abnormal TCD, which shows that you have an increased risk of getting stroke, and you put them on hydroxyurea, studies have shown that it sort of reverts. It goes back to the normal state for lots of them. And so in the situation where chronic transfusion is not available, hydroxyurea puts itself in it such that you can use hydroxyurea. Because I have had some patients who were having abnormal TCDs, and just on HU, when we repeated, their TCDs have normalized. And when that normalizes, then you know that then it shows that that patient risk for stroke has reduced. And then that patient doesn't need to be on chronic transfusion. But if your HU is not working, then you might have, in spite of all the other complications that might be coming, you might have to use the chronic transfusion. Okay, thank you.
Thank you very much. I see Priscilla Ashite. Yes, Priscilla, please unmute and go ahead.
Thank you very much, and good evening to us all. Doctor, thank you for the information. It's really helpful. Yes, I want to know if when they take blood transfusion, it's risky for them or not. Are they at risk when they get to the point that they have to take blood transfusion? Thank you.
So thank you. So for blood transfusion, there are always indications for blood transfusion. Blood transfusion is not a free lunch. When you are giving blood transfusion, you have to know that it can come with different complications, okay? Transfusion reactions and all that. So you need to be certain that this patient needs the transfusion before you go ahead and give them. So if the patients fit in all the requirements for a transfusion, they need a transfusion, then it won't be a problem for them. But if it's not an indication, patient has a good HB, doing well, the heart rate, the respiratory rates are all okay, then you might not need to go ahead and transfuse because they are indicators for transfusion. So all those indicators, you have to make sure that the patient fits the indicators before you transfuse. Otherwise, it can cause lots of problems for them. Acute lung injury, circulatory overload, compatibility, and patients can die from blood transfusion reactions. And so, and then you must sensitize them, especially if you continue giving them transfusions after transfusion. And such patients react a lot to your transfusion. So you need to make sure that your patients really need the blood, and then you can go ahead and then give it to them. Okay, thank you.
Thank you very much.
Thank you. Any other question? So I see two questions in the chat box. One is from Na Apia. How do we manage sickle cell patients who are pregnant? What are the red flags and how do we manage them?
So normally for sickle cell patients who are pregnant, they are treated as a high-risk pregnancy. And so for them, we normally, at CAD, we normally give them special doctors to take care of them. And so that from the time that at some point they will tell you that come 1 month, come 2 weeks, come whatever. For them, it's not 1 month that you let them come. They are given shorter periods. They are monitored, especially with their HB, because the pregnancy itself makes you anemic. And so when you have SCD, you have a higher chance of getting anemia. And then that is when a lot of them will also will have all this recurrent vaso-occlusive crisis. And so when you have them, you have to make sure that the doctor's mind and everything is on them, making sure that they come to their clinics and then all the investigation that has to be done, they give it to them. If a patient needs blood, they are given blood transfusions, but as much as possible, any breathlessness, anything, no matter how slight it is, any fever, no matter how slight it is, such patients are brought in onto the ward so that they are managed appropriately. They are not taken for granted because it is a high risk pregnancy. Okay.
All right, Dr. Paintsil, thank you. There's a question from Gideon asking that can hydroxyurea be given for life, or is it given for only a certain period? And can you get to a point where it becomes ineffective if you've taken it for a long time?
Okay, so currently, from evidence that we have, people have been using it for a long time and it is still effective in them. But we need to know that there are a few group of people that we call them non-responders. So those groups which are non-responders, most of the time when you give them hydroxyurea, it doesn't work. And so that small percentage of people might not benefit from hydroxyurea. Otherwise, you can give it for life. But in pregnancy, normally we tell them that before you get pregnant and then during pregnancy, it is recommended that you get off your hydroxyurea, both for the male and then for the female. So we tell the male that if you want to go and impregnate a woman, please make sure that you stop your HU for like 3 months before you think about having any babies. That precaution basically is because most of the time we don't really, there's really no study into what is happening in pregnant women. So nobody wants to stick their neck out, especially to say that I'm going to do a study on pregnant women to see whether hydroxyurea is teratogenic. That is unethical. So that study will never happen. But at least a precaution is being taken such that as much as possible, patients who are pregnant are not given hydroxyurea. But there are some few people who took it hydroxyurea, but studies have shown that they didn't have babies who were abnormal. Okay, but it is still not recommended.
Yeah, please, on the question of hydroxyurea, just for education purpose, is it indicated in only particular genotypes, or it can be given to all sickle cell patients?
So normally, we give it to those who have SS and SB beta 0 thalassemia. So they are the severe disease. But there are a few of our SC. Normally, we say that SC patients have a milder course of the disease. But when you have some of the SC, they can have a severe outcome. They are the ones who will come hospitalization every day, severe anemia, needing like every month coming for transfusions. So if you have an SC patient who has a severe phenotype, having complications upon complications, you can give the hydroxyurea to them. So we have a few SC who are on hydroxyurea because they have a severe disease. Okay. But it's basically for all SS and then S beta 0 thal. From age 9 months of age, you can start the drug for them.
Thank you very much. All right, so Gina is asking the medication voxelotor. What are the benefits for sickle cell?
Okay, so voxelotor, basically, we know that one problem that the sickled RBC does is that it releases oxygen and then it becomes sickle. So voxelotor targets that, such that it increases the RBC's affinity for oxygen. So if your RBCs have oxygen, then it doesn't sickle because the S doesn't polymerize. And so basically that is what voxelotor does. And it's an oral medication that is used for them. Okay. And crizanlizumab also targets the adhesion molecules, specifically the P-selectin. So if you inhibit adhesion molecules, your RBCs doesn't adhere together. And if it doesn't adhere together, it doesn't cause obstruction, doesn't cause vaso-occlusion. And so patients don't get the pain that they normally won't get. Okay.
Fantastic. Thank you very much. We still have some bit of time. So if anyone has a question, once again, please raise your hand or type in the chat box and we'll give you the opportunity. This has been very educative and very informative. Anyone with question?
Son's genotype is SF. F for Samuel and F for Frank. May I have some education about it? And he gets the crisis. Yes, S and F.
Okay, so I spoke about the newborn screening and then the test that is used in the newborn screening. I believe that your child was screened during the newborn age because when you do your newborn screening, it gives you the specific percentages of the different hemoglobin subtypes. So if you have a baby, mostly what you normally have, the predominant hemoglobin that's when newborn babies have is the F. And then as you grow, as the baby grows, by 6 months of age, that F percentage reduces. And then that baby has whatever hemoglobin type they have will increase in percentage. So if you have a baby who is an A, normal hemoglobin, no disease, what the isoelectric focusing will tell you is that baby has FA. And so as the baby grows, the F percentage will reduce. And then if you do your HB electrophoresis, possibly by one year of age, all it will see is that it will tell you that it is an AA. And so the same happens when you have a patient with S. What it tells you is that the patient has an FS for the newborn screening. And as the patient grows, the percentage of the F reduces, and then the percentage of the S also increases. And so as that patient grows, that patient will be an SS patient. So if you do your other tests like your HB electrophoresis, it will tell you that it is that patient has an SS disease. Okay, and not only for SS, if you have an SC patient during the newborn time, it will tell you that that patient has FSC. But later on, you know that that patient will be an SC. Okay, so if you have an SS, that is the homozygous of the severe cause of the disease. And so this patient, possibly your son might need, if the child is not on hydroxyurea already, might be an indication that you might have to start the patient on hydroxyurea.
The electrophoresis test was done when the boy was 6 years.
6 years.
And we had it at Lancet, and it indicated that he's S and F. My worry was that I also read, yes, at 6 years, he was still having the SS. So my worry was that when I asked the doctors, then they said that then it will be hereditary persistence F, something persistence of what? Fetal hemoglobin also.
Yeah. So mostly if you have the hereditary persistence of fetal hemoglobin, you normally don't have lots of complications and crises like someone who doesn't have. So if he has a high F percentage, F is protective. It reduces the chance of him having lots of the crises and then the complications. But the best would have been possibly to do another test we call the HPLC, which normally gives us the different percentages. It will tell you S is 60%, F is this percentage, and then if you compare that, then it helps you to know what to do. But if the patient has a high F percentage, it is mostly protective, and such patients normally do well.
Maybe we'll take the last two questions and then we'll wrap up. Gideon is asking about CC genotype, whether it can be classified as having a sickle cell disease or it's a different kind of hemoglobinopathy. And then we'll add Gina. Gina also is asking that which are the drugs that are available? Is it only hydroxyurea or there are others? And then finally, she's asking what is NAD and NADH?
Okay. So mostly if we talk about CC genotype, it is a hemoglobinopathy, and it is not sickle cell disease. Okay, it is a hemoglobinopathy. So hemoglobinopathies are abnormal hemoglobin gene, but it is not a sickle cell disease, because in the beginning I said that a sickle cell disease is when you have two abnormal hemoglobin gene, one of which is hemoglobin S. Okay, so you can have S, you can have C. That is a sickle cell disease, but you can't have two CCs. And most of the patients who have CCs, it's a mild hemoglobinopathy. Most of them don't even have complications, but it is an abnormality. If you have CC and then you marry someone who has an AS, you can give birth to a child who has an SC disease. And then the second question was, okay, so hydroxyurea, as I said, hydroxyurea is what is normally available here in the country. The others, they are not. I know that L-glutamine and dairy, I'm not sure it is available here. I'm not sure. But crizanlizumab in clinical trials, we are using it. Voxelotor, also we are using it. All these three are available at high cost in the, if you go to North America, they are all available because it's FDA approved. But in Ghana, what we have is a hydroxyurea. Okay. And the other one for the NDA, it's all about biochemistry.
Okay. Dr. Semensa has a hand up. Dr. Semensa, please unmute and then ask your question.
Thank you. Please wanted to find out if so in Ephraim's case, if the child would have been stable and not having crisis, would you have gone ahead to still give the hydroxyurea?
Yes. So if he's stable, if you check the full blood count, the HB is like always around like 6, 5, 6, 7. It's an indication that you have to give your HU. Normally, our target is to have that hemoglobin level around 10. If patients get a hemoglobin level around 10, then the fatigue that they normally experience reduces. And so it is always recommended that that is our target. And so even if you have your FF and then the patient has any discrepancies with your hemoglobin, an occasional crisis, the HU mostly helps them. And so we will normally give it to them. Okay. That we should advise them about how to reduce. It's an SC and then gets crisis almost every 2 months. Advise how to reduce this crisis. So normally, what we normally advise is that there are some basic things that you normally have to do. The clothing, especially in this part of this weather, which is rainy and all that, making sure that the patient gets good clothes. And then good nutrition, hydration, good hydration, making sure that their immunization also is up to date. And then on their medications always. And apart from them, if your daughter is always getting crisis, that might be an indication that we might have to start on some hydroxyurea for this child. Because I said that for SC, we normally take it by a 1 based on its individual base, so that if this child is having crisis, we might have to put on hydroxyurea and then monitor this child closely. This is not a child you leave to go for like 3 months without coming to the doctor. No, because when you give hydroxyurea, especially for those with SC, some of them have a high hemoglobin level already. So if you don't monitor them, this patient can get a very high HB, which might be detrimental to their health. And so you can put them on hydroxyurea and then monitor them closely so that we see how it goes. But most of the time, when you put them on hydroxyurea, it improves their, we call it rheology of the red cells, how the red cells are, hydrates them, reduces polymerization. And so with that, it reduces the occurrence of crisis that patients mostly is having. So if you're not in any clinic, please come to a sickle cell clinic so that we can manage appropriately.
Dr. Pencil, please tell us when you run your clinic.
So normally we run the sickle cell clinics on Mondays, on Tuesdays, on Thursdays and Fridays in consulting room 10 at Komfo Teaching Hospital. But
in the mornings,
in the mornings, apart from that, I know a lot of other sites also run sickle cell clinics. I know Asopa runs sickle cell clinic. I know MCHH also runs some sickle cell clinic.
And KNUST Hospital, we run ours on Mondays, afternoon from 2 to 5. Somebody's asking, is the clinic free?
You need to come with your health insurance. Healthcare is, if you come with your health insurance, then it covers a small top up. And then, yes, and then the adult clinic is on Thursdays for sickle cell in consulting room 1.
All right, Dr. Pencil, thank you very much. I think this has been very useful. Miriam just typed, GPHA Hospital in Takoradi runs a sickle cell clinic too. Great, thanks for letting us know. All in Takoradi are invited. Miriam, please add the day and then the time for the clinic. And it's quite interesting that most of the sickle cell clinics are centered around Ashanti region or Kumasi and then Accra, while the Savannah region has no clinic at all. So I think there's a lot of work for us to do in terms of building capacity of healthcare professionals to be able to have a clinic where patients with sickle cell can report for care. Because the key thing is that when you have a chronic medical condition, you need to have a particular facility or a particular doctor that can be attending to you on a regular basis. Professor Abuto, okay.
I wanted to give a recommendation in addition to what Dr. Peadiatric had said in relation to the control of the disease. I think that I'll use KNUST as a typical example. Over the years, our students come and they are screened for many conditions, and I think including sickle cell disease. But some way, somehow, our students are unable to, either they don't go for their results or their results are not released to them. So even in the 5th year, when you ask the class, how many of you are aware of your status? I can tell you less than 10% know about their sickle cell status, even though right at the 1st year, all of them mandatorily, I think, go through the test. So I'm wondering how we can resolve this, because as Dr. Paintsil said, if you know your status, then we are one step ahead of trying to controlling the disease, because in effect, you can make an informed decision as to which partner you go with. I'll give you a very simple scenario here. A young lady, a banker, came to see me together with her supposed partner, who were previous students or post students of KNUST. When they came to school, they had a test, but unfortunately, the guy said he only knew that he was negative. The lady knew he was AS, so nothing more was done. And by the time they were supposed to go get married, it turns out that the man is AC, then the lady is AS. So that potential, as Dr. Pencil explained earlier, with regard to the possible children they could have, they have this problem. So I wish that any organization that can be of help including our own KNUST, should help in this endeavor.
The message is clear to all of us that we should all be ambassadors of creating awareness. Thank you so much, Professor Akoto. Thank you. We'll invite Prof. Mrs. Ibokodro to share her remarks before we have the vote of thanks and closing prayer. Prof, please go ahead.
Okay. Yes, good evening. And Dr. Vivian Paintsil, we are very grateful. I think I've learned a lot. As I'm thinking, I'm imagining and asking myself a lot of questions because we have made a lot of mistakes and people don't know their status and we don't even help them because we think that stigmatization, somebody will say this and that about us. I think that is one thing we need to look at to help people come out and check their status. So what I've gathered today is that I should make sure when I get to my classroom, I should get my students and ask questions if they have done it because it's important. So I suggest that we all do the same. The other thing is that instead of stigmatization, I hear the voice telling all of us, provide support. Be that support that they can lean on. Be that support that can help improve their quality of life. Be that support that can provide the psychological support for them. And so let us all live here with that mindset that we need to be each other's keeper and be ambassador. That is the word I wanted to use. Dr. Z says that I'm a evangelist for physical exercise. Now I'm calling all of us to be evangelists for sickle cell so that we can all move this and help people to check themselves, go for the test, encourage them to do that. And I want to say that because you said nutrition is also key, we also have decided that we will bring nutrition to the people. So every month we have time with a dietitian. So mothers and those who are with this situation can link up and ask questions just like they were asking today. What shall we do? What can we eat? What is it? Like she says, drinking a lot of water and so on. You can also provide them with things that can help them in their eating so that they can live well. The man made me very excited. He says he wants to live up to 90. And I'm very excited that that's the mindset. And all of us should carry that mindset and help them to live long and live well. On that note, Doc, I'm very grateful, and the team Novartis, we are thanking you. We thank everybody that joined us also, because it's a good thing to do. Thank you, Dr. Isibwatun. Over to you.
Thank you to Prof. Mrs. Odro. You've done so well in moving all of us and initiating this. We'll call on Dr. Anokye Brokwa to give the vote of thanks, and then Dr. Eric Odro will give the closing prayer. We have a video of a patient with sickle cell to share with you. It's just a short video. Please, when we are done, please stay on. I'm sure you'll be encouraged by his words. So Anokye, please give the vote of thanks.
Thank you very much, Dr. A.C. Boateng. Thank you for giving us the opportunity to be here today. First off, we would like to thank God for the opportunity to even gather. At a point in time, we saw about more than 90 participants joining in. It means that everyone was very, very interested in how this was going to go. And we are grateful for that opportunity to have been able to gather here today. We are also grateful to the Wellness Center being a center of excellence and bringing this very, very important disorder to greater light. And then the University Health Services to also giving us the opportunity to bring this here today. For Novartis Ghana and their dedication and their competence with advocacy, we are very grateful to you. To Dr. Vivian Paintsil for making time out of your very busy schedule. We saw that you have 80 peer-reviewed articles. It means that you've taken a lot of time to do a lot of things over the years. And so we are very grateful that you were able to spare us a bit of your time this afternoon to give us such wonderful insight into this age-old disorder. We'd also like to thank Mr. Peter Amponsa, who was so vulnerable about sharing his journey with us. He's been with us at the Sickle Cell Clinic for quite some time, and we just want to say thank you to him for sharing his experiences with us. Thank you, Dr. Esi Boateng, for moderating this afternoon, and to our wonderful audience for engaging with our platform this afternoon. We are very grateful for your presence. I wanted to end with a short quote from Mr. Paul Marlow, the founder of Never Alone, a mental health and mental growth group. It says, waking up daily in pain is a constant reminder that you are alive. It is not something you asked for, nor wanted to happen to you. Instead of letting it win and push you down, use it as a base to build up. Build up your positive morning routine. Build up your daily exercise routine. Build up your healthy eating routine, and build up your overall mental and personal growth. Use this pain as a launching pad to better yourself. I pray that for all of us who may be sufferers, who may have the traits, who may have one or two friends or family members who are suffering from it, we will take a cue from Paul Marlow. Thank you for your time. Have a lovely evening.
Dr. Anokye, thank you too for thanking us. Thank you so much. That was fantastic. 3 key things to remember. Sickle cell disease is not a contagious disease. Children with sickle cell disease should be allowed to live normal lives, normal childhood, and then seek help when you need it because help is available. And Dr. Eric Odro will give us a closing prayer.
Thank you, Dr. Siboateng. Shall we pray? Our gracious Father, we thank you for such a moment as this. We thank you for giving us life to be able to experience such a webinar, such an insightful webinar as such. We are very grateful to you for this opportunity. We thank you, God, for Dr. Vivian Paintsil and what she's been able to impact to us, the information on sickle cell that she's been able to deliver to us. We are grateful to you, O God, for giving her to us. We ask that, Lord, you would replenish everything that she's lost, every energy that she's lost in preparing for this webinar. We also ask that, Lord, you would also protect all those living with sickle cell, all those who are going through one challenge or the other, the families that are living with children and relatives with sickle cell. We ask, O God Almighty, that your comforting hand will be with every one of them. We are asking, O God Almighty, that as ambassadors of sickle cell, we would carry our duties to the fullest and bring glory to your name. We thank you for everyone that has been able to join. We ask, O God Almighty, that we continue to live in good health as you have always done for us. We thank you and bless your holy name. In Jesus' name we pray. Amen.
Amen.
Amen. Thank you very much. So we have a short video. Please stay on, and when the video ends, then the webinar ends. Thank you all very much for joining. July is the Sickle Cell Awareness Month.
Hello, I'm Peter Amponsa, a staff of the university with the finance office, but currently posted to the Faculty of Agric. I'm a sickle cell person with the SS genotype. It's been a hell, but in all, I'll say God has been good. A lot of people think sickle cell persons just fake, those especially who have not encountered, and even those who have encountered sickle cell persons, some because they don't feel it within their own bodies, they think it's just something that is ordinary. But let's put it this way, If, let's say, you are having a headache and you take a simple paracetamol and it relieves or goes within, say, 30 minutes, and compare it to somebody who is a sickle cell person, either an SS or SC person, and even sometimes people who are AS and AC people also would have some pain here or there, just that they cannot be referred to as sickle cell persons. You take your simple paracetamol and it's gone. But the sickle cell person will go on and take stronger painkillers, even to the extent of taking those narcotic medications, and yet still be in pain. Sometimes you may not have an idea of what the pain feels like. Somebody sitting somewhere may think you are just dramatizing, but it's real. The challenges are enormous. The complications are more than you can imagine. We have emotional, psychological, and social issues. My own personal experience, I've gone through a lot. I had to repeat in the primary school for about 2 times before finally I got to the secondary school. When I was at Opokuwari secondary school, during my secondary school days, fine, things went on well. Not without challenges, not without occasional stays in the hospital and all that. But what broke the camel's back was when I was writing my final WAEC exams. Right after the physics practicals, I was a science student. I did physics, chemistry, and maths. Right after the physics practicals, I couldn't walk out of the lab. Even though I was able to successfully do the lab work, I had to be carried and brought straight to the KNUST hospital here from Santasi, Opokuwari to this hospital. I had to write all the other papers whilst on admission at the hospital, having blood transfusion and infusions, so both hands were occupied. Every time that I had a paper, the infusion and the transfusion had to be taken, and I would have to be transported all the way to Opokuwari, because along the line they said they couldn't get invigilators to come to the hospital to help me. And so I wrote all the papers this way. I'll go to Opokuwari school, write, come back to the hospital, and then the process will continue. It has been so. When I came, I had to divert from science to do accounting as a result of these things. This sickle cell thing is really real. The amount of money I spend monthly on medications and other things just to make sure that I go and come, you may not have any idea about it. If I want to go on, I can go on and on and on. But I just want to let you know that if you are yet to get married or you are contemplating, please make sure that you go by what has been told you, by way of trying to find somebody whom you are compatible with in terms of sickle cell or any other blood disorders. Please, if you perchance meet any sickle cell person, know that every day he or she lives with pain in his or her body. Well, a lot of sickle cell persons have passed on. I've met many who have passed on. It is just by the grace of God. But there have been sickle cell persons who have lived well over 60 years. My own mom was an example. She was 66 years before she passed. I have told myself I'm going to be 90 before I go. But if I will be able to turn that 90, I need your support. Or people like me need your support. My resolve is that nobody should ever suffer sickle cell. So carry out the message and tell people to test before they say I do. Because it is not easy. You, the parent, what you go through is so much for you to carry. If you have to wake up deep in the night to rush your child to the hospital, if your child, when he grows, have to rush in the deep of the night to rush him or herself to the hospital, then you realize that it is not an easy task. So please, do not joke with this education that is going on all around. Take it serious. The monies that I have used on medication for myself, if I had built a 4-story building, maybe I would have completed by now. So please, kindly make sure that you test. And any time that you meet any sickle cell person, we don't need any sympathies of yours. We need only your empathies. We don't need you to be tired of us, but we need every encouragement of yours. We need every support of yours. Not that we are weaklings. Yes, we are struggling. I work for myself, I feed for myself, I tend for myself. I may not need your money, but I need your encouragement and your support. Thank you for listening and watching. And I hope you would make sure you test before you say I do. Okay, so on this note, I would want to gladly invite you all to join the webinar that is going to go on the 12th of July, which is going to be in collaboration with the KNUST Wellness Centre and then the KNUST Health Services, as well as Novartis Ghana Limited, on the topic sickle cell. So please avail yourself and invite others. Thank you.